Alright everyone, welcome back to this channel. This is Dr. Sam, and today we are going to discuss one of my favorite topics, which is prosthodontics, for this week 4 of INBDE practice questions. Alright, so let's get started. So the first question for today is going to be about Kelly's combination. So it is, in Kelly's combination syndrome, we will be seeing which of the following. And option 1 is mobile anterior ridge, papillary hyperplasia, overgrowth of the tuberosities, resorbed mandibular posterior ridge, or all the above. Alright guys, take a moment to think about it and let's see. So as you can see in this image over here, this is where the mobile anterior or the flabby ridge is located. Okay. And then there's obviously a lot of papillary hyperplasia in the palatal area. The maxillary tuberosities are overgrown. It is all very, very flabby. The bone resorption is to the max. So it's all very flabby. That is the reason why most of the dentures don't fit appropriately. And then there is extrusion of the lower anterior teeth and mandibular bone resorption as well. Okay. So the answer for this is obviously all the above. Fairly easy question to start with. Let's go to the next slide now. When boxing the impression, we need dash from the edge of the impression to maintain our borders. Now, most of the times, guys, these prosthodontic questions tend to be easy because we follow these things in the clinics or in the labs. So most of the times, all of us would know the answers for these. But if you don't, then please remember that you need at least 2 to 3 millimeters of width from the edge of the impression in order to maintain your borders. So this is your beading wax. You need at least 2 to 3 millimeters from the edge of the border of your impression, okay? And the boxing wax, the height of this is usually more than the beading wax, okay? So the answer for this is 2 to 3 millimeters. It's kind of a tricky one if you don't read it appropriately. This is the size that we want to know, okay? The next question. The typical survey line is in the incisal third in the near zone and at the junction of the incisal and the middle thirds in the far zone. And then the answers are, options are, both statements are true or false, or one is true, one is false, or the other way around. So let's see. Think about this. What do you think, guys? What should be the answer? Alright, so for this one, we are going to divide the tooth into the near zone and the far zone. Near zone is where the clasp usually starts, or there is a rest space on that side, okay? And the far zone is the other side. So near zone and far zone. And now I've colored this part into 3 colors. The yellow part is the incisal or the occlusal part. The green part is the middle third, and the pink part is the gingival third. Now, as they are asking you, typical survey line. Typical survey line is here. If you put this on this black line is your typical survey line. It starts in the middle of the middle third and it ends at the junction of middle and the gingival third. So typical survey line starts at the middle, not at the incisal. So the first half is wrong. And then it ends at the junction of middle and gingival, not at the junction of incisal and middle. So the second half is also wrong. Both of these lines are false. So in this way, if you just remember this diagram on the top with the colors, you would be able to identify most of these lines. The only thing you need to remember is this typical one, which is only in the middle. The typical one is mainly only in the green part, okay? The atypical is the one which goes in all 3. Then atypical B is also only in the incisal. Atypical C is only in the gingival. The atypical A is the only one which goes from the incisal to the gingival thirds. Okay? And that way you'll be able to remember much better. Alright, so let's go to the next question. The next question is about the vertical dimension of occlusion. When it is developed for an edentulous patient, and it results in over-opening, then what can happen? Excessive leverages are developed and will result in ridge soreness and may initiate the ridge resorption, or the patient will speedily get accustomed to the aesthetics resulting from this, or no difficulty will be encountered in speech or masticatory ability, or the patient will appreciate a stronger self-image. What do you think will the answer be, guys? Alright, so let's see. In this option here, in this photo here, this is the normal vertical dimension when the person is occluding. So this is VDO. When we have bone loss or when we have tooth loss, the VDO reduces. When we age even more, we have excessive bone loss and tooth loss, or in an edentulous patient, this is how the VDO is. From this, it has reduced to this. Okay. So now, what is vertical dimension at occlusion? Vertical dimension when the teeth are touching normally, that is your vertical dimension of occlusion. And what is the dimension of occlusion at rest? When there is a little bit of space in between your teeth, when the teeth are not touching completely, or the freeway space or the rest space. That is normal, and you need this for your muscles of mastication to relax. But in this situation where it is over opened, as per the question, the teeth are in this position. Okay, the teeth are in this position. So everything is loaded. The muscles of mastication are continuously loaded. There is no rest. Okay. So the teeth are going to get, there is going to be a lot of soreness. The dentures are going to click. There will be muscle and joint pain. And in general, the patient will complain that the smile looks too full. There's too much of white part in this mouth. Okay, too full. So yes, this will be the correct option for this question. Okay. Alright, so let's go to the next question. The purpose of a faceboard transfer is to locate the interpupillary line, to articulate the maxillary cast in relation to the condylar hinge axis, to articulate the mandibular cast in relation to the condylar hinge axis, to record the anteroposterior and the mediolateral spatial positions of the maxillary occlusal casts in relation to the transverse opening and closing of the patient's mandible. Now this number D option is the perfect. This is what we need your faceboard transfer for. Okay. So if we have to choose this option, it is present in option 1 and in option 4. So 2, 3 and 5 are gone. Then is it to locate interpupillary line? Now interpupillary line, that means the line between your the pupils, it can be straight if the person has a squint and has some eye problems. It cannot be straight. So we don't need the facebow to locate the interpupillary line. So this is a misconception. We don't need that. Do we articulate it based to the maxillary cast or in relation to the mandibular cast? Now, maxillary cast is stable. We have to base it to the articulate the maxillary cast in relation to the condylar hinge axis, because everything else, the mandibular jaw is not stable, it is moving. So we have to use the maxillary cast in order to articulate it. Okay, or we have to articulate the maxillary cast in relation to the condylar hinge axis. So the answer is going to be B and D. Okay. Alright, so let's go to the next question. So the next question is question number 6. When planning an implant retained overdenture, the edentulous ridge should be evaluated for. What should it be evaluated for? It should be evaluated for a minimum bone height of 12 millimeters, some amount of bone width, and presence or absence of attached gingival tissue, or all the above. Alright, think about it, guys. What should it be noted for? So when we are planning for an overdenture, obviously, yes, we need to see the minimum bone height. The minimum bone height should be at least 12 millimeters. That's correct. Okay. The minimum bone width should be at least 6 millimeters. The width of this bone out here should be at least 6 millimeters. Okay. Why should that be 6 millimeters? Because most often the width of the implant can be what? It can be from 2.5, 3.5, 4.55, or even max up to 6. Let's say most common it will be 3.5 to 4 or 2.5 to 3.5. Around those, if that is the diameter, then you need at least 1 millimeter of bone surface on both the sides. So if you consider 4 millimeter as the average most often used implant diameter in the posterior teeth, then you need to have at least 1 millimeter on both the sides of the, or all the sides of the implant. Okay. Then presence or absence of attached gingival tissue. If you have attached gingival tissue, that means your bone is still present. Okay. Now, when you have teeth and you're planning for a single missing tooth to be replaced with an implant, then also make sure that you have at least a minimum of 7 millimeters of space available. Okay. This should be at least 7 millimeters when it is a single tooth. And why is that? Because, as I said here, you need at least like 4 millimeter if you say most commonly used implant, 3.5 to 4, and then you need 1.5 and 1.5 on each side. So in between a tooth and an implant you need 1.5 millimeters, and in between two implants you need 3 millimeters. So this image from Glidewell Labs is like amazing. In between the tooth and the implant should be 1.5 millimeters. In between two implants should be a minimum of 3 millimeters of space should be available when you have multiple implants next to each other. If you just have a single implant which is needed, then you need to have that 1.5 and 1.5 on both the sides. If you consider 4 millimeter implant, then you need to have 1.5 and 1.5 for the crown to kind of come out like this, right? So 7 millimeters is needed minimum. And also when you're calculating implant space, you calculate for the crown height as well, and the crown height should be at least what? 15 millimeters. Okay. Alright, so let's go to the next question. The following photo shows a surgical template used in the implant surgery. The surgical template can provide a surgeon with what all things can a surgical template provide? Angulation of dental implants, mesiodistal position of the dental implants, buccolingual position of the dental implants. This is a really easy one, so the answer is going to be all the above, because obviously when you have a surgical template or a stent, then you know if you need to place an implant at this angle or straight up. You also come to know how much space you need to leave in between, that is the mesiodistal position of the dental implants, and also the buccolingual, how much space you need to leave on the buccal and the lingual aspect of the implant. Okay. Alright, so let's go to the next question. Which of the following regarding an immediate denture are correct? Primary function of the immediate denture is to maintain the patient's appearance. Immediate denture requires more chair time and additional appointments. Immediate denture should be worn for the first 5 days without removing. During the first 6 months after the insertion of the immediate denture, maximum amount of changes in the supporting tissues are expected. Alright, think about it, guys. What do you think would be the answer? Now, obviously, it's an immediate denture. It's for the appearance, for maintaining the appearance of the patient. So, 1 is correct. And it does require more amount of chair time and a lot of additional appointments for adjustments. That is also correct. Should be worn for the first 5 days straight up without removing? No, that is absolutely wrong. They are supposed to keep it inside their mouth only for the first 24 hours because that helps in hemostasis and preventing, reducing the bleeding and all of that. Yes, of course, there are going to be sore spots, but it also helps in molding their tissue space appropriately around the dentures. Okay, and after that, they can remove the denture, clean the denture, and place it back inside the mouth. It is advisable to wear the dentures as much as possible, evenings included, for the first 1 to 2 weeks. And after that, take them out, put them back in, and wear them only during the daytime. They have to remove it during the nighttime when you are sleeping. Okay? And then the fourth option, during the first 6 months after the insertion, maximum changes are expected in the supporting tissue, is also correct. So answer D has all of them. So this is the answer. And the next question is, during the evaluation of a complete denture patient, your patient whistles on S sound. What would be the most likely reason? Alright, think about it, guys. These are about the sounds. Okay, so let's say this is your maxillary arch and this is your mandibular arch. Okay, when the maxillary arch is narrower than normal, then there will be whistling. Okay, when the maxillary arch is wider than normal, then there will be lisping. Okay, in terms of denture patients. Now let's see what happens when people actually have teeth. When people have teeth, and you change their incisal positions because of some smile designing or something, or one of the teeth falls down and you're placing a implant or a bridge because of trauma and all 4 teeth are gone, or something has happened. If you're changing the front part of the teeth for a patient, then many times there will be changes in the way the patient sounds. And the key to understanding any changes in speech is to understand that the first thing necessary to identify is which sound exactly is the patient struggling with, and how much time has the patient has to adapt to these changes. Because if a patient is born like this, not born, when they had it and they have been using their teeth like this for 10, 15, 20 years, for them to suddenly change to a new tooth position with the teeth up till this size is going to be a little hard because there's muscle memory, right? And most often the F and the V sounds are the ones which cause all the problems. Okay, and the F and the V sounds are when we say 55, the incisal edge of the lower lips almost touches the vermilion border, the wet dry line. The incisal edge of these upper teeth touches the vermilion border of the lower lip. If the incisal edges are, this is when it is 55, okay, this is the F sound. If the incisal edges are impinging into the lower lip, something like this picture, that means this is more like a class 2, skeletal class 2 relationship, and it has over erupted maxillary anterior teeth. Okay, so you have to reduce this one and then eventually maybe do a crown lengthening or just treat it with orthodontics if possible. If not, what happens when a person says the S sound? When a person says S, we check it with 61, 62, 63, right? In that case, this is normal. This is how the person would say 61, 62, 63. Okay, this is how the teeth would be in this position. About 70% of the people would say 61, 62, 63 like this, in this position or this position. About 30% of the people will say S like this, with their teeth behind. Now, if you did a smile design case in such kind of a patient, and if you've changed only the upper teeth, then yeah, when you're trying to correct the positions, or when you're trying to correct the S sound, you will have to adjust on the lingual contours of the upper or on the incisal contours of the lower teeth, because the S sound is produced when the tongue interacts with that little space in between those two teeth. If this lower tooth is touching here because the cingulum area is thicker on the upper, or the lower tooth is restored and the incisal edge of the lower is higher, then that S sound will not be perfect. And so whatever you've treated, identify that part and try to change it. If it's a veneer and this part is compromising, then you might need to adjust the incisal edge, the lower incisal edge. Or either ways, check how the restoration is and then appropriately adjust in your patients. Okay? And most importantly, have the patients use their current restorations or the new restorations for at least 4 weeks before you try to change any of these, before you try to do any of these changes in the porcelain, so that there are no problems. Okay? Because many a times by 4 weeks, the muscles and the tongue will kind of get used to the new positioning and be able to pronounce quite properly. Okay, so you might not need to change or damage the porcelain at all. All right, so we are here at the last question now, which is about border molding. So when you're border molding the distobuccal area of the mandibular custom tray, what movement and or action would determine the correct extent of the denture border in that area? Think about it, guys. What would be the correct movement? Would it be ask the patient to open and move the mandible from side to side? Or ask the patient to open while you exert downward pressure on the mandible? Or ask the patient to whistle, or ask the patient to say the letter S? In the distobuccal area of the mandible. So I'll tell you the answer. The answer is ask the patient to open while you exert downward pressure on the mandible. This was quite easy, actually. All right, my friends, that's all for today. If you have any questions or doubts, please let me know in the comment section below, and I will be happy to answer those doubts for you. Hope you discuss all of these questions with your friends when you're studying for your prosthodontics part of the INBDE exam. Good luck for everything. Adios for now. Until next time.